Very good morning to all of you. Thank you, FPA, for calling me again to your annual conference. It's a pleasure to be invited by FPA year after year, and it's great to be here. Thank you so much. So today I'm going to be talking about pacemakers. All of you probably have heard and know a bit about pacemaker, and I'm going to talk about what you already know, which is what has been there in the world of pacing for last so many years, and also what is new in the world of pacing. So these are the objectives of my talk today. We'll talk about the role of pacemakers, the basic pacemakers in the management of bradyarrhythmias. We'll then talk about some specialized devices. Again, you've all heard of these devices. ICG, which is used to prevent sudden cardiac death. CRT, which is a device which is used to treat a certain subset of patients with heart failure. And then finally, the latest kid on the block, you can say, leadless pacemaker. This is what I will be talking about mainly. So these are the four cardiac devices. We'll be talking about pacemakers for bradyarrhythmia, ICDs, which give shock and treat tachyarrhythmias, CRT, which improve heart function in patients with weak heart or heart failure, and then leadless pacemakers, which are new devices without any leads inserted directly inside the heart. So again, and most of you would have seen these videos and would know what a pacemaker is.
Right, let's go. Okay.
It is about the size of a couple of stacked silver dollars and weighs approximately 17 to 25 grams. It is usually surgically placed or implanted just under the skin in the chest area. The device sends a tiny electrical pulse down a thin coated wire called a lead into your heart. This stimulates the heart to beat. These impulses are very tiny, and most people do not feel them. While the device helps your heart maintain its rhythm, it also stores information about your heart that can be retrieved by your doctor to program the device.
So this was a normal pacemaker, a simple pacemaker device which has one or two leads, one in the atria, one in the ventricle, and these leads are implanted by us and they are attached to the heart muscles with screws. And these leads monitor the heart rhythm, and whenever the heart rate goes below a certain rate that we can set, usually 60, then they give electricity to the heart so that the heart can beat at a normal regular rate. And the indication for pacemaker implantation are these: SA nodal disease or AV nodal disease. I'm not going into the anatomy of that. I'm sure you remember it from your MBBS days. Sinoatrial disease and AV nodal disease. So this is an example of sinoatrial disease or SA nodal disease. These are ECG showing P wave, QRS, P wave, QRS, and then there's a long pause. Nothing happening here. So this is called sinus pause or sinus arrest, and this then can lead to symptoms like dizziness. This is an example of what is called tachybrady syndrome, another indication for a pacemaker. So this is not working. Can we have a laser projector that works? Pointer? Anyway, it's not working on this screen, but basically what it shows is you have this tachyarrhythmias here, heart rate going very fast, and then it slows down for a long period of time. Again it goes fast, and then again there's a slowing of heart rate. So there is a tachycardia and bradycardia in the same patient. This is a condition which is otherwise very difficult to treat, because to treat tachycardia you will give them rate limiting drugs like beta blocker, and if you give them those beta blocker drugs, it slows the heart rate even more and causes blackouts. So if you have tachybrady syndrome or sick sinus syndrome, you need a pacemaker. So pacemaker in sinus node disease is indicated for symptoms. So this is one of the important messages I want to give in this talk, that for sinoatrial disease or sick sinus syndrome, a pacemaker should be implanted only if the patient has symptoms. So for example, you do a Holter on somebody and the Holter shows the 3-second pauses when the patient is asleep. Would you put a pacemaker? No. Okay? Pacemaker is only implanted if patients have daytime pauses which is causing symptoms, not otherwise. In the absence of symptoms, for 6 sinus syndrome, no pacemaker is required. For AV nodal disease, it's completely different. For AV nodal disease, and there is an example of that, you can see P-wave, QRS complex. P-wave, QRS complex. Here it's very clear, QRS, QRS, QRS. So for every QRS complexes, there are 2 P waves, and the PR interval is the same. So this is an example of 2:1 AV block or Moody's type 2 AV block, and this is an indication for pacemaker even in the absence of symptoms. What is this? P wave, QRS, PPQ, but there is no definitive relationship between P wave and QRS complex. So this is an example of complete heart block. So another type of AV nodal disease, if you have AV nodal disease like 2:1 heart block or complete heart block, then that's a clear-cut indication for a pacemaker. So permanent pacing in AV block is indicated for second-degree heart block or complete heart block, whether symptoms are present or not. Because if you don't put a pacemaker, it can lead to sudden cardiac death. So the message is, what I am trying to emphasize, for SA nodal disease, pacemaker is indicated only if symptoms are present. For AV nodal disease, even in the absence of symptoms, one should put in a pacemaker. So that was pacemaker. The second device that we use, that we implant in cardiology, is called ICD, or implantable cardioverter defibrillator. It is again like a pacemaker, but a slightly bigger device, which is used to prevent sudden cardiac death. All of you know this, large number of sudden cardiac death, 80% or more, are due to ventricular tachyarrhythmias, which is ventricular tachycardia or ventricular fibrillation. And in 85 to 90% of sudden cardiac death, the first recognized event is this. Most patients have recurrent event, and survival rate of episode is less than 5% even in developed countries. In a country like India, where there are no defibrillators in public places, most of these cardiac arrests out of hospital end up in disaster. All patients die. This is what an ICD looks like, just like a pacemaker, slightly bigger, and it has again leads just like a pacemaker, and this lead is slightly bigger, slightly thicker, and the device just sits there and monitors heart rhythm. And if the heart goes into a tachyarrhythmia, like a ventricular tachycardia or ventricular fibrillation, then the device gives an electric shock to the heart immediately and brings the heart back to normal. The indications for putting an ICD: survivors of cardiac arrest due to VT or VF, hemodynamically significant ventricular tachycardia, prevent sudden cardiac death in patients with poor ejection fraction. And this is actually at the moment one of the largest indicator of implanting ICDs. ICD for primary prevention of sudden cardiac death. Patients who have poor ejection fraction, patients who have had myocardial infarction in the past, patients who have an ejection fraction of less than 35%, they are at a very high risk of getting ventricular tachyarrhythmias, and they can die suddenly from VT or VF, and ICDs can prevent that. ICDs are also used in certain inherited heart disease. These are very rare indications because these conditions are not very common, like hypertrophic cardiomyopathy, arrhythmogenic right ventricular cardiomyopathy, and Bravada syndrome. All these are rare conditions, so I'm going to talk a lot about it. Moving on from ICD, the other third type of device that we put is CRT, or cardiac resynchronization therapy. CRT is a device that is used to improve the symptoms and longevity, prognosis in a subset of heart failure patient. So who benefits from CRT? These people. People who have an LV ejection fraction of less than 35% and who have a left bundle branch block morphology on the ECG. So not everybody with an EF of less than 35 will benefit from CRT. People who have normal QRS complex, they don't benefit. People who have left bundle branch block, they typically benefit from a CRT device. Don't know whether this will play or not. So a CRT is just like a pacemaker, but a pacemaker has two leads. A CRT in addition has a third lead, and this third lead is implanted into the coronary sinus. So if you all remember your cardiac anatomy, coronary sinus is a vein of the heart that collects blood from myocardium and then drains into the right atrium. So what we do is we pass a catheter, a sheet first of all into the right atrium and try to engage the coronary sinus. And through that pass a wire and then a lead into one of the branches of coronary sinus and implant a lead there. This is what it looks like. If you can see, this is one lead, this is second lead, and this is the third lead that goes into the coronary sinus branch and gives electricity directly to the left ventricular lateral wall.
A CRTP is a pacemaker with an additional lead on the left ventricle. A traditional pacemaker utilizes leads in the right atrium and right ventricle. It continuously monitors the heartbeat and, when necessary, delivers tiny, unnoticeable electrical signals to keep the heart from beating too slow and to maintain a heart rate prescribed by your physician. The additional lead in a CRTP is placed on the left ventricle of the heart to coordinate the pumping functions of the two lower chambers so the heart pumps efficiently.
So this is a good example of an echocardiogram showing what the heart looks like without CRT and with CRT. It improves the heart function. I'll play it again so that you can appreciate. There is ventricular dyssynchrony. This part of the ventricle is not moving with this part, whereas in this slide they are both moving in a synchronized way. So CRT is implanted in patients with heart failure, ejection fraction less than 35%, who have a left bundle branch block morphology. And by doing that, it improves heart function and prognosis. So these are the three devices that we have been putting for years: pacemakers for sixth sinus syndrome and AV nodal disease, ICDs to prevent sudden cardiac death, and CRT for heart failure patients. So what is new in cardiology? Better hardware. All these devices that we put have become smaller, lighter, and the quality of leads have improved tremendously. The device longevity has also increased. Previously, these devices used to last 8 to 10 years. Now they are lasting 18 years. The devices are much smaller, full body MRI compatible, and nowadays there is Bluetooth connectivity available with some devices. What is leads?
5 minutes more.
Yeah, leadless pacemaker. So leadless pacemaker, and I'll show you how we do it. There are some problems, although they are not very common, associated with traditional pacemakers. There may be lead fracture, lead related complication, there may be device infection and erosion. And a leadless pacemaker prevents all these complications.
The Avera LP implant procedure begins by using the Avera.
We implant it from the IVC, inferior vena cava, from the leg. We go up.
The device are then inserted and advanced to the IVC. A pliable, braided protective sleeve fully covers the LP.
This is what the pacemaker looks like.
To reduce risk of damaging the helix or injury to cardiovascular structures. The LP is interrogated using the Merlin PCS programmer, and communication is established. The device is then advanced.
This is right atrium, it goes into the right ventricle.
A contrast injection is performed to allow proper visualization of the chamber and identification of a target location. The typical target location is the distal septum. Once at the target location, the protective sleeve is unlocked and retracted, exposing the Avera VR leadless pacemaker. The device is advanced until it contacts the myocardium to allow for mapping of the location. Initial capture threshold, R waves, and impedance measurements are performed. If satisfactory measurements are confirmed, fixation begins. The device is rotated 1.5 turns to fully fixate it. The device contains a radiopack chevron that can be seen under fluoroscopy and is used to assess the rotation of the leadless pacemaker. The catheter is placed into tether mode to allow for final testing prior to release. Additionally, to verify stable helix fixation, a deflection test is performed. When ready to fully release the pacemaker, the catheter tethers are misaligned by pulling and rotating the white LP release knob half-turn counterclockwise. The delivery catheter is withdrawn. For acute or long-term retrieval of an implanted.
So this is what the devices look like. There is an atrial device in the right atrium. There is a ventricular device in the right ventricle, and these two devices are connected to each other again via Bluetooth technology, so that atrial ventricular synchrony is maintained. The device gives electricity first to the atrium and then after a while to the ventricle. So these devices are quite long lasting. It's a very new device. It came into the market last year only. The manufacturers claim that they last anything between 17 to 20 years, but most studies show that they last between 12 to 15 years, which is also a good time. And after 12 or 15 years, if the battery runs out, it can be retrieved and new pacemaker can be implanted. These are the benefits of a leadless pacemaker. Reduce invasiveness, there is nothing, there is no scar, performed under local anesthesia, invisible to the patient, no pocket, no lead related complication, less procedural time, better outcome, lower complication, and it is completely MRI safe. So in conclusion, pacemaker, ICD and CRTs have been around for some time, but the technology keeps evolving. Leadless pacemakers are the new kid on the block and may offer more option to the patients needing pacing therapy. Thank you.
Thanks a lot, Dr. Shutia, for completing within this stipulated time. We learned a lot about the newer pacemakers, and your video clippings are very much interesting to us.
Dr. Siotia is requested to come to the selfie zone to receive the memento from our very founder, very dear senior member, Dr. M.B. Gala. Dr. Manha Gala to present the memento to Dr. Anjan Siotia. This session was sponsored by, was supported by BM Birla Heart Research Center. We are grateful to them. Now over to Dr. Chandan Pal for the next session.
Yeah. Our next speaker is Dr. Debraj Yash. He will be speaking on recent advances in the management of COPD. He is from Manipal Hospitals. May I request Dr. Debraj Yash to please come to the podium and start his deliberations. Dr. Yash is a senior consultant pulmonologist at the Manipal Hospital EM Bypass. And he'll be speaking mainly on advanced international pulmonology.
Good morning everyone. It was always a pleasure to see so many number of delegates at such an early period of the time. So I will be speaking on recent advances in the diagnosis and management of COPD, and will be focusing, because whenever we used to talk about the recent changes in the management of COPD, we always take into account the gold guidelines. So what are there in the gold guideline, and also what are the things which are in the pipeline, not in the gold but may come into the future gold guidelines. So I will be speaking on that. So over the 15 minutes, the topic which I will be focusing on, number one, definition. Number two is a concept of treatable trait or phenotype based treatment, which was more in the asthma, has now encompassed into the COPD, or whether there is any requirement of separating the asthma and COPD into two different entities or not. Third one is the development of newer drug, and when I am talking about the newer drug, I will also be talking about whether there is any beneficial effect of newer bronchodilators, be it ultra-lama, be it ultra-lama, whether they are going to change the management of COPD, although they didn't have any kind of mention in the recent gold guideline also. Fourth one is the emphasis on the peripheral eosinophil count also in the patients of COPD. Biologicals, I have put some question marks, although there is a definite effect of the biologicals on COPD, but it is not as that crystal clear as that of the asthmatic. Last one is the pre-COPD or the PRISM, and the last one is the bronchoscopic lung volume reduction. So first I will focus on the key changes, what has happened over the time period. So number one is the information on spirometry updated. So what are the changes in the spirometry updated? Now Gold 2025, it recommends using pre-bronchodilator spirometry to rule out COPD and post-bronchodilator to confirm the diagnosis. This is a huge change. Previously, whenever we used to confirm the diagnosis of COPD, we always take into account the post-bronchodilator value. Post-bronchodilator FEV1 by FBC less than 0.7, it is COPD. But now they are also saying you are doing the pre-bronchodilator COPD to rule out. Because if it is already greater than 0.7, then you need not to have the result of the post. Always you will perform the spirometry, but it is not that much important. This is the flow chart. So if FEV1 by FBC is greater than 0.7, the pre-bronchodilator, it is not COPD. Then measure the post-bronchodilator FEV1 by FBC if volume responder suspected, that is low FEV1 or high COPD, high symptoms. So even in a patient of COPD, although the reversibility is more in the asthmatic individual, even in a COPD patient with a high significant bronchodilator reversibility, it usually indicates a good response to the bronchodilators. So always do a bronchodilator reversibility test even in a patient of COPD. Now if the FEV1 by FBC it is less than 0.7, then measure the post bronchodilator FEV1 by FBC. If it is greater than 0.7, obviously ruled out, and if it is less than 0.7, COPD diagnosis is confirmed. This is one of the important trajectories of FEV1 also. Every individual, irrespective of their ethnicity, irrespective of their age, irrespective, they will have a decline of the FEV1 with progression of the age. But there are some individual or certain individual who will have more decline of the FEV1 with progression of age. Those who are, this is a particular type which is called as rapid decline of the FEV1, and some of them will not have that much decline. So early COPD, it is only a research term. Early COPD, it is very difficult to diagnose an early COPD because it is a mainly pathological term. Whenever you have the early changes of the COPD which is happening, so it is a research term. Mild COPD, airway obstruction severity, young COPD less than 50 years of age, PRISM, that is the preserved ratio with FEV1 less than 80%, that I will focus on. Second thing is that what is there in the guideline, that is the changes, high prevalence of the cardiovascular diseases in stable patient with COPD. We all are aware of this fact that IHD, myocardial infarction, arrhythmias particularly are so much common, heart failure, hypertension, all are common. Now the implication of is that there is a bronchodilator called as vilanterol. Now many of us are using vilanterol. So it has been told that vilanterol has a beneficial effect on the cardiovascular aspect in patients of COPD. So vilanterol may be used in those patients, although I am again reiterating that fact that it is not mentioned in the GOLD guideline as the management. But there has been sufficient literature to prove that in patients with COPD with cardiovascular diseases, you may use vilanterol as your preferred bronchodilator in addition to any LAMA, because we all are aware of that fact that isolated LAMA cannot be used in patients of COPD. Now, exacerbation of the COPD, a SUMMIT trial, if you see what are the mechanisms. COPD lung inflammation, it drives the systemic inflammation, it promotes the atherosclerotic damage in the heart and vasculature, number one. That is why it is a systemic disease. Number two, hyperinflation, it will compress the lung vessel which will lead to reduced cardiac output. Third one is the hypoxemia, which can lead to pulmonary hypertension, right heart failure and myocardial infarction. So, should we routinely check for cardiovascular abnormality during an exacerbation of COPD in the OPD or within a month after exacerbation? Please do at least an echocardiography test in any patient of COPD, number one. At patients admitted with exacerbation, you may send pro-BNP or the other features suggestive of the right ventricular overload. If you are suspecting any kind of pulmonary embolism, then only send D-dimer. CT coronary angiography not routinely. It is a domain of the cardiologist to decide whether it is required or not. And preventive aspirin, heparin, statins, these are not recommended still. Now CT scan, there is a change use of CT in the stable COPD. So whether we should do CT scan in all patients of COPD. If you have an OPD patient, it need not to do CT scan in all stable patients of COPD. CT scan is done to rule out other differential diagnoses which may mimic as COPD, because you are seeing an individual in the OPD with classical symptoms, you have auscultated, based on the POT you have made a diagnosis of COPD. But in COPD patients also 30 to 40% they may have bronchiectasis, they may have some post-tubercular CTUD, some kind of changes may be there. So, frequent exacerbation with excessive cough and sputum production, number one. Symptoms out of proportion to the disease severity. Second one, in those subset of patients in whom you are considering some kind of bronchoscopic treatment, in those patients also CT scan is mandatory. And third one, because smoking is both a risk factor for COPD as well as lung cancer, also for the lung cancer screening program. Identifying multimorbidity, I will not go into the diagnosis. This is a good forest plot. You can see the COPD comorbidities detected by CT versus clinically diagnosed. The red one is detected by CT and the blue one is clinically diagnosed. So if you do the CT scan, you can diagnose the comorbidities at least twice than it is diagnosed clinically. Now, there are certain terms which has been there in the new gold guideline. Number one is the genetically determined COPD, like alpha-1 antitrypsin deficiency or those things. Number two, COPD due to abnormal lung development. Number three, smoker COPD. Four, COPD due to biomass and pollution exposure. Fifth, COPD due to infection, COPD and asthma, COPD of unknown cause. Now this is the most important thing for all of you. How do we classify COPD patient and how do we give treatment to a stable COPD patient? So first you need to diagnose the COPD, for which spirometry is mandatory. So if FEV1 post bronchodilator is less than 0.7, then you will have a diagnosis of COPD. Then you measure the airflow obstruction, gold 1, 2, 3, 4 based on 80%, 50 to 79, all of this. Now you see what are the symptoms and what is the exacerbation. There is a change now. Even a moderate exacerbation history will put the patient into exacerbator type. Previously it was only one severe exacerbation, but now even a one moderate exacerbation, patient will fall into exacerbator type. So A, B, no exacerbation based on the symptom. How do we calculate the symptom? 2 score, MMRC, very easy to calculate. Second one is the CAT questionnaire, you need not to remember, it is always there in the Google, or you can have a questionnaire based on that. So A, B and E. A, less symptom, no exacerbation. B, more symptom, less exacerbation. E, with an history of the exacerbation. Now, is the patient, how do we give treatment? First thing to ask whether we have given any treatment to the patient of COPD, whether patient received any treatment or not. If the answer is no, then we will go to this chart. In this A, B, E, based on which we will give the treatment. Group E, LAMA plus LAVA. Group A, only bronchodilator. And Group B, LAMA plus LAVA. And inhalational corticosteroid to be given when there are history of exacerbation, when there is peripheral eosinophil count greater than 300. Those are the things, or the symptom CAT score or MMRC, those things are higher. Then only we will give the inhalational corticosteroid. Follow-up treatment also we will adjust based on the persistent dyspnea as well as the history of the severe exacerbation. So this is the follow-up treatment. I will not go into the details. Now these are the new molecules. This is a molecule which has been advocated by Gold, still not available in India, will come sooner. This is ensifentrine. Previously we used like roflumilast, we used doxycycline. So ensifentrine is a dual phosphodiesterase 3, dual or phosphodiesterase 4 inhibitor. It acts on multiple sites. Number one, bronchodilator, acts on the airway smooth muscle. It will lead to relaxation. Number two, neutrophil, eosinophil and lymphocyte. It has an anti-inflammatory effect. And third one, it has got a mucociliary clearance effect by CFTR. So it plays three roles, ensifentrine, and the trial, the Enhance 1 and Enhance 2, so which advocated the use of the nebulized ensifentrine and the improvement of average FEV1 as well as the secondary things like the total number of hospitalization, history of exacerbation, all those things have been taken care of. So ensifentrine has been advocated for use in the treatment of the COPD by Enhance 1 and Enhance 2 trial. Now coming to the biologicals. So which are the biologicals which can be used in patients of COPD? These are the two trials, the Boreas and the Notus trial, which advocated the use of the dupilumab, which has come into also the Gold guideline. One is the Boreas and the Notus trial, the dupilumab. So dupilumab, it acts on the anti-IL-4 receptor. We still not available in India, but will come very soon, probably this year. So what are the inclusion criteria in which we will use dupilumab? Number one, the peripheral eosinophil count greater than 300, uncontrolled COPD patient, history of repeated exacerbation, and the exclusion criteria is that at least patient has to be on any kind of or maximum dose of COPD treatment for last 12 months. Dupilumab, I am not going detail into the other literature. Now pulmonary hypertension. So COPD patient, always you do an echocardiography to see whether there is pulmonary hypertension or not. Now previously whenever there is pulmonary hypertension, we always used to give the treatment of the hypoxia and we do not use any kind of anti-pulmonary hypertension drugs for the management of pulmonary hypertension associated with the COPD. But there are certain drugs which are in use, most of them have found to have no significant effect. Now coming to the vaccination, changes for people with
About 4 minutes left, please.
Yes, sir. So yearly influenza vaccination, number one. COVID-19 we all used. Pneumococcal, same as any kind of normal other individuals. RSV vaccination for individuals greater than 50 years. Tdap vaccination to protect against pertussis and zoster vaccine to protect against shingles for COPD greater than 50 years. These are some of the AI model for COPD. I will not go into the details of the AI model. Lung volume reduction surgery referral, persistent dyspnea despite optimal initial medical therapy and completion, severe obstruction which is accompanied by air trapping, which was manifested by increasing the total lung capacity and residual volume, emphysema, predominant HRCT scan, BMI less than 35 and absence of uncontrolled, but it is mainly with upper lobe predominant disease and impaired exercise capacity have the most improved outcome. Endobronchial valve, coil, and these are the things. I will not again go into the details. These are targeted lung denervation, rheoplasty in COPD, stem cell therapy. These are also have got some kind of mention in the Gold guideline, not advocated in the very early stage. Now, why precision? I will finish my talk by focusing on this. Why precision medicine is now recommended in COPD individual? Because there is a clinical variability in the clinical presentation. There is no correlation between the clinical variables at the patient level and how they are performing. Also, a number of the clinical variables are associated with the outcome, and we have specific therapies for each and every patient type, and also there is a variability in the clinical response. Now, what are the treatable traits? This is not visible clearly. The first one is insufficient inhaler technique. So I am not treating the COPD patient as a whole. I am treating each and each subsegment or which can improve the outcome. So if a patient is not taking the inhaler properly, I am educating the patient. Type 2 eosinophilic inflammation. So if my patient is having type 2 eosinophilic inflammation, how do we know type 2? Absolute eosinophil count, sputum eosinophil count, or even by high FeNO we can have an idea about whether the patient is having eosinophilic inflammation or not. So if the patient is having type 2 eosinophilic inflammation, we will always recommend inhalational corticosteroid in those type of patients. Smoking, if we just ask the patient.
2 minutes to go, please.
Yes, sir. Smoking, also treatment of the obesity as a whole, not just saying the patient you need to reduce the weight, by a concordant team of dietitian, physiotherapists, including pulmonologists, cardiologists, physical inactivity, anxiety, depression, all of the things. So purpose of the GOLD guideline is to provide the evidence-based recommendation. It will serve only as a tool for the clinician worldwide to improve the outcome, but there are certain criticism, like GOLD guidelines, the most of the study population is from the Western population. It doesn't take into account the COPD patient of Africa and Asia. Spirometry limitation, it is exclusively based on the spirometry, and some of the individuals will not be sufficient if we just go by the spirometry. Limitation and need for the individualization, practical consideration, clinical judgment and decision making, and also real world things are not as they are seen in the trials. To summarize, GOLD guidelines represent the most authoritative evidence-based research. They should be used as a dynamic framework but not as a rigid protocol. Clinical expertise and individualized patient care remain the paramount importance, and awareness of the regional realities and evolving evidence require flexible application of the recommendation. Thank you very much.
Thank you, Dr. Josh, for that elaborate and comprehensive discussion.
Dr. Josh is requested to come down to the selfie zone to receive his memento from Dr. R.K. Jalan, ex-secretary, ex-president, and a very senior member of the Family Physician Association, Kolkata. Two humble requests on my behalf to the audience. There is a lot of talking going on in the back, which is impeding with the speech of the speaker. Number one, please, if you have to talk, please whisper at the back. Don't impede into the talk of the speaker. Number two, as soon as the speaker gets down from the audience, if you have to catch up with the speaker, do it outside the auditorium, not inside the auditorium. Please catch up with the speaker outside the auditorium. Now, this session was supported by Monipal Group of Hospitals, who have got several outlets in our city of Joy. The next session also is supported by Monipal Group of Hospitals. I request Dr. Rajiv Dhal to invite the next speaker to the dais.
Yeah. Our next speaker.
Dr. Jalan honoring Dr. Debraj Josh with a memento. A loud round of applause from the audience, please.
Yeah, ladies and gentlemen, our next speaker is Dr. Professor Rajiv Dale. He is from Manipal Hospital and he will be speaking on the overview of BMT, bone marrow transplantation, and the Indian scenario. Dr. Dale, please.
Good morning to all of you, and my special regards to the organizing committee of FPACON for giving me this opportunity to speak on a subject which is very close to my heart, that is bone marrow transplant. My topic is overview of bone marrow transplants and Indian scenario. I am attached to University Medical College as professor as well as clinical lead in the Department of Clinical Hematology, Hemato-Oncology and BMT, Manipal Hospital. Now, bone marrow is a source of blood cells. It was detected in 1868. but it took around 100 years to perform the first successful bone marrow transplant. So when we knew how to destroy the bone marrow in 1945, at that point of time we didn't know how to regenerate the bone marrow. And then in 1990, some clinician got Nobel Prize in medicine to standardize the process of bone marrow in the world. And since then, every year the number of bone marrow transplant are increasing in the world. This is the CIBMT USA data. If we go to the European data, we also see that number of bone marrow are increasing year by year, and the number of haplotransplant, that is half match transplant, is rising exponentially, depicted by the blue line. Now, what is bone marrow transplant? Basically, we know that bone marrow is a blood producing factory. So like every factory, it is a schematic diagram, and from which the blood cells are produced. So like every factory, the industry may be in trouble, like it may stop producing blood cells. We call it hyperplastic anemia or aplastic anemia. There can be defective end product produced from bone marrow. We call it myelodysplastic syndrome. There can be immature blood cells. We call it leukemia. So for all kind of this bone marrow related problem, the curative answer is bone marrow transplant. Now, initially we used to do bone marrow transplant. Now we know that entire bone marrow is not required to replace our new bone marrow. It is a stem cell which regenerates the bone marrow, and the special property of stem cell is, along with differentiation, it has a property of self-renewal. That is, one stem cell can produce similar kind of another stem cells. And if we replace the bone marrow with the stem cells, then it can regenerate the bone marrow. So now we call it hematopoietic stem cell transplant and not a BMT as a whole. So this is the, from hematopoietic stem cells, all the mature cells are produced. So the bone marrow or hematopoietic stem cell transplant, it is an intravenous infusion of hematopoietic stem cells collected from either bone marrow, peripheral blood or umbilical cord blood to re-establish the hematopoietic function in patients with damaged or defective bone marrow or immune system. So bone marrow transplant is done not only for hematological disorder but also disorder of the immune systems. If we consider the greatest threat of today's world, it may be terrorism. Now, how to deal with that? One way we can see now, this is one way of handling, do carpet bombing. But if we even do carpet bombing, we can't eliminate the last terrorist from our society. So, to eliminate the terrorism, we need a system where the terrorism can't exist. So that is the principle of bone marrow transplant. By bone marrow transplant, we are not only changing the bone marrow, we are changing the immune system. The recipient gets the immune system of the donor. So all the residual leukemic cells which are there in the body, they are immunologically replaced by the new immune system. So that is the principle of bone marrow transplant. There are grossly two types of transplant. One is autologous, when the patient's own stem cells is utilized, and another is allogenic stem cell transplants, which can be divided into match-related donor, match-unrelated donor, haplo or 50% matching transplant, because in today's nuclear family, we don't get a sibling donor to have a full match. So we are now doing a 50% match or haplo transplants or cord blood transplant. So in autologous transplant, patient's own stem cells are used, and these are the indications for autologous transplant, that is multiple myeloma, non-Hodgkin's lymphoma, Hodgkin's lymphoma, some solid tumors like neuroblastoma, germ cell tumor, even in some autoimmune disorder also bone marrow transplants are used. In allogenic transplants, first we need to do the HLA typing, and we need to collect the stem cells from the healthy donor after HLA matching. And then we destroy the bone marrow of the recipient or patient, and then infuse. The way we infuse the blood, we transfuse blood, that way we infuse the stem cells. These are the indications for allogenic bone marrow transplant. Malignant indications are usually acute leukemia, AML, ALL, CML in blast crisis, myelodysplastic syndrome, so on and so forth. And the benign indications are aplastic anemia, thalassemia, sickle cell, other hemoglobinopathies, etc. Where from we can get the stem cells? One is matched sibling donor, which is ideal, but there is only 25% possibility of getting a matched sibling donor within the family. So these are the alternative donor: match unrelated, half match, and umbilical cord. So we need to do the HLA matching first, because HLA is transmitted like a Mendelian inheritance. And after the HLA matching, then we select the donor, and then we do conditioning. What is conditioning? Conditioning is the very high dose intensive chemotherapy or total body irradiation by which we destroy the bone marrow of the patient. Otherwise, the body of the patient won't accept the transfused stem cells. So there are different protocols. I am not going to detail, but the main motto is to destroy the patient's own bone marrow. And then the stem cells are collected. How it is collected? One way of collection is from bone marrow. That is, we collect the bone marrow of the donor. But the problem is we need to collect huge amount of bone marrow for the bone marrow transplant. For bone marrow test, we collect around 0.5 to 2 ml of bone marrow. But for bone marrow transplant, we need to collect at least 400 to 500 ml of bone marrow, which is challenging, associated with a lot of complications. So nowadays, we collect stem cells from the peripheral blood. What we do, we mobilize the stem cells from the bone marrow to peripheral blood by giving some medications, and then by this apheresis machine, we collect it from the stems from the peripheral blood. So it is called peripheral blood stem cell transplant. We know that stem cells are there within the bone marrow in the stem cell niche. It is attached with the bone marrow stromal cells. Now, it is removed from the stem cells, are removed from the bone marrow to the peripheral blood by utilizing this mobilizing agent like growth factor, different types of chemotherapy, as well as plerixafor. So we mobilize the stem cells, we break the bond between the stem cells and the stromal cells, and those stem cells are released in the peripheral blood, and from the peripheral blood, by apheresis machine, we collect the stem cells. Now, umbilical cord is a very rich source of stem cells, but there are a lot of issues with umbilical cord blood. It causes slower regeneration of the bone marrow because of the prematurity of the umbilical cord blood stem cells. So nowadays, worldwide, the umbilical cord blood transplant is not recommended. So now, in last 1 year in India, no umbilical cord blood transplant was done. So umbilical cord blood transplant is now out of fashion. So we collect umbilical cord blood transplant, it can be done. Now after stem cells transplant, we can cryopreserve with DMSO. We keep it in -80°C, and whenever stem cell is required, we thaw it and we infuse it. The way we do blood transfusion, RBC transfusion. So no surgical intervention is involved in bone marrow transplant. And after that, it takes around 2 to 3 weeks time to form the new cells. We call it engraftment. When after bone marrow transplant, the count becomes 0. Then when the neutrophil count is more than 500 per microliter, we call it neutrophilic engraftment. When the platelet count is more than 20,000, we call it platelet engraftment. So it is the sign that our body has accepted the stem cells and bone marrow started producing new cells. But the picture is not that much rosy because it is associated with a lot of complications. It can affect from head to toe the complications associated with bone marrow. The most common complication is definitely infection. So there can be engraftment syndrome, there can be the reactivation of viral reactivation, infection, febrile neutropenia. So whole lot of complications may be there, and we need to handle all these complications during transplant. But the most dreaded complication is graft versus host disease that we know, where the donor's T lymphocytes, they consider patient's own organ as a foreign, and there can be acute and chronic graft versus host disease. It can affect your skin, your liver, your gut, and we need to give immunosuppression for prevention of graft versus host disease, and if it occurs, we need to treat that with steroid and now newer molecules. I am not going into details of that. The thing is, it is like a new birth bone marrow transplant. So after bone marrow transplant, the immunological memory is completely lost. So it takes post-transplant 6 months to 1 year time to develop a full-fledged immune system. After that, we need to do vaccination. The way we vaccinate a child, the same way, after 1 year of bone marrow transplant, we need to vaccinate the patient, the entire vaccination. So there is a protocol for that, we need to follow. This is the vaccination protocol, I am not going to detail. Now, infrastructure is very important. Why infrastructure is important? Because when we destroy the patient's own cells, there is no immunity at all. So, own common cells becomes pathogenic for that patient. And it takes 2 to 3 weeks time to generate a new blood cells, a new neutrophils. So, during that period, patient needs to be kept in a HEPA filtered room, in a positive pressure HEPA filtered room. And it should be well designed. There are some criteria for that. I am not going to detail. So these are the air handling unit of bone marrow transplant unit. So if we don't do, then whatever transplant we do, the patient will die because of infection. So that we need to control accordingly. Now post-BMT follow-up is very important, dedicated post-BMT follow-up because of a lot of complications, blood vessel host disease, vaccination, so on and so forth. So this is a brief overview. Now what is the status of bone marrow transplant in India? The first bone marrow transplant occurred in Tata Memorial Hospital way back in 1983. Since then, the number of transplants has been increasing. Now there is a body in India, that is Indian Society for Blood and Marrow Transplant. As per the ISBMT registry data, we are now doing around 4,000 bone marrow transplants in India every year. And again, if we see, the number of haplotransplants are increasing because we are not getting matched sibling donor in our nuclear family. So we are doing now half match transplant or haplotransplant. It is associated with few complications, but we need to deal with that, and we have special protocol for that. These are the indications for which bone marrow transplants are done in India. The most common indication are multiple myeloma, followed by AML, and then thalassemia. If we consider the indications for bone marrow transplant, suppose in Europe or America, their preference is leukemia, followed by myeloma. But here in India, the second most common cause of transplant is thalassemia. So it is the benign indications for which the most of the bone marrow transplants are done in India, and then leukemia also. Now this is the one thalassemia patient transplanted in Norris Medical College. Last year it was the first bone marrow transplant for thalassemia. Now what is the uniqueness of bone marrow transplant compared to other solid organ transplant? Number one is, in bone marrow transplant, donor is not losing any organ. They don't need to donate any organ. We are collecting only the stem cells. Number two, no surgical procedure is included. We don't need to go to operation theater for doing bone marrow transplant. It is done in the BMT room because it is infused the way we infuse blood products. And in solid organ transplant, lifelong immunosuppression is required because the patient's own immune system is intact, and we have implanted a foreign organ of the donor. But in bone marrow transplants, the entire immune system is changed. So usually after 6 months to 1 year, no lifelong immunosuppression is required. Cost and outcome, I haven't written it because it depends on the type of the transplant, indications, and place to place. There is an Eastern Hematology Group consisting of 10 states of India. Yeah, sure. So under that, there is a group called EIBMCT, Eastern India Blood, Marrow and Cellular Therapy Group. We have 22 centers in the Eastern region for doing bone marrow transplants, and we have 9 centers in West Bengal and Kolkata. These are the list of different bone marrow transplants in the Eastern region. Some of the states doesn't have any centers, but here in West Bengal we have 9 centers, both government and private centers who are doing bone marrow transplants. The first bone marrow transplant in entire eastern region occurred in Nilotan Sarkar Medical College way back in 2009, and so every year the number are increasing. We have 22 centers now. Till date, we have done more than 2,000 transplants in the eastern region. Last year, we have performed nearly 400 transplants in the entire eastern region. So the numbers are increasing. So future of stem cell transplant, just few words. We know the main problem of bone marrow transplant is graft versus host disease. So where we collect stem cells from the donor. But the thing is, suppose in leukemia, in malignancy, if our own T cells can be trained against the tumor antigen, then nothing like that. So we can cure the leukemia, and there is no possibility of graft versus host disease. So that is the principle of CAR T cell therapy, where the patient's own T cells are trained in the laboratory against the specific tumor antigen of the patient and then re-infused. So it is called a living drug. Here the patient's T cells are by lentiviral vector, transducted by an CAR T, chimeric antigen receptor, and then those T cells are again re-infused to the patient. Those T cells just targets only the tumor cells and not any organ of the patients. So basically, that is a process. We collect the stem cells, or we collect the T cells from the patients. We train the T cells against the tumor antigen, re-infuse the T cells to the patients, and those re-infused T cells only destroy the tumor cells. So we got success in CAR T cell therapy for ALL, B-cell ALL, for lymphoma. So that is the future of transplant, where we can cure leukemia or any malignancy, but we can avoid GVHD. So take home message is, the countries who so-called the first world country, they are doing around 250 to 400 transplants. 250 to 400 transplants per 10 million population. In India, we are doing 15 bone marrow transplant per 10 million population. So we need to increase our bone marrow activity at least 10 times to meet up the requirement of India. So as far as our eastern region is concerned, we are doing bone marrow transplant in eastern region. We are doing bone marrow transplant in Kolkata. We are doing state-of-the-art BMT for all possible indications, be it thalassemia, be it leukemia, be it aplastic anemia, and our outcome is comparable to any BMT centers in the world. So be self-sufficient. We will do our BMT in our region only. So that should be our motto, and my motto of this talk, that we will be doing BMT in our region only. Thank you. This is the thalassemia patient say transplanted.
Thank you, Dr. Rajiv De. Please come here to the selfie zone to receive your memento from Dr. Shamsul Huda, ex-secretary of the Family Physician Association, Kolkata. We bid goodbye to Dr. Chandan Pal and Dr. Rajiv Dhal for chairing so many sessions and taking out valuable time. Please come down.
Thank you, Dr.
Please come down to the selfie zone to have a photograph with the chair, with the speaker. A big round of applause for the. Hello. Last two sessions were supported by Monipal Group of Hospitals. Dr. Shamsul Huda presenting a memento to Dr. Rajiv De, and Dr. Rajiv Dhar and Dr. Chandan Pal to accompany the presentation. Please repeat it once again. The next two sessions will be supported by Apollo Hospitals, Apollo Group of Hospitals. And may I invite the two chairpersons, Dr. Vishwambar Agarwal, a very senior member of the Family Physician Association, Kolkata, and Dr. Rishikesh Kumar, Senior Vice President of the Institute of Neurosciences, Kolkata, to be on the dais, have a copy of the program with your hand, and proceed with the next session. Loud round of applause for the new chairpersons, Dr. Vishwambar Agarwal and Dr. Rishikesh Kumar. Dr. Rishikesh Kumar is the Senior Vice President of the Institute of Neurosciences, Kolkata, and Dr. Vishwambar Agarwal is a well-known senior member of Family Physician Association, Kolkata. Dr. Agarwal and Dr. Kumar, please proceed with the first session.